1 in 4 New Zealanders will face fertility challenges. This time can be lonely, isolating, confusing, and traumatic. Kia ora koutou. I'm Lydia Hemingway, and I'm the CEO of Fertility New Zealand. Thank you for joining us tonight, and welcome to the Fertility New Zealand webinar series. Fertility New Zealand walks alongside all people facing fertility challenges. We do this by providing support and information services and being the voice of this community through our advocacy work. I encourage you to jump onto our website and check out our services and connect with us on social media. Tonight, I am so pleased to introduce you to Dr. Anna Bashford, who is our wonderful guest presenter. Anna is a fertility specialist and gynaecologist working at Fertility Associates. While IVF has helped millions of people around the world to achieve their dream of having a family, many IVF cycles end in frustration and heartache when embryos fail to implant in the uterus and develop into a fetus. This is despite the continuous improvements in IVF and success rates. Tonight, Anna is going to dive deep into this topic with us. At the end, we'll have some time for questions, so pop any questions you have in the chat, and we'll go through them after Anna has finished her presentation. All right, over to you, Anna.
Hi, thank you for having me, Lydia. Before I start my talk, I just wanted to go over some terms that are important. And I know most people will know this, but a euploid embryo is a normal embryo, which means it has the 46 chromosomes, which is 23 pairs, with each pair inherited from each biological parent. An aneuploid embryo means that the embryo may have more or less chromosomes. I'm going to talk about ESHRE quite a bit, which stands for the European Society of Human Reproduction and Embryology. And I also mentioned SART, so I just wanted you to know what that was. That is the Society for Assisted Reproductive Technology, and it represents the majority of the IVF clinics in the USA. So recurrent implantation failure is a term to describe the failure of multiple IVF cycles or embryo transfers. There has been an absence of consensus on the definition of recurrent implantation failure, and this led to the Lugano workshop, which was a group of US and European specialists who came to define recurrent implantation failure. They focused on euploid transfers and medicated cycles, and then they also went on to define recurrent implantation failure in untested embryos. They did this by basing the definition on the number of embryos transferred and the woman's age and the likelihood of aneuploidy. So the important thing from this workshop was the definition means that it needs to be a sustained implantation so that you see a sac on scan. And it includes biochemical pregnancies, and that's important in that it differentiates implantation failure from pregnancy loss. The year later, ESHRE produced good practice recommendations, and they had a similar definition. The definition means that recurrent implantation failure is less common than we thought initially, and that we've probably been overdiagnosing this. We now know that less than 5% of couples having IVF will have implantation failure, and this is based on a study which showed that if you had 3 euploid embryos transferred, at the end of that, 95.5% of couples would have an ongoing pregnancy. So the definition basically is the failure of 3 euploid embryo transfers, or if the embryos are not tested, how many you would expect to have back before an ongoing pregnancy. And what this means, for example, is if you are, for untested embryos, if you are age 35, you have recurrent implantation failure if you have had 4 embryo transfers and don't have an ongoing pregnancy. Whereas if you are 41 or 42, if you've had, it would not be till you've had 13 transfers that you would be considered to have recurrent implantation failure, based on the fact that 70% of the embryos are likely to be aneuploid. And this is just from the good practice recommendations from ESHRA, showing a similar model for clinicians to use. The failure of multiple transfers is very frustrating, and it's led us to look for causes and also interventions which may help couples. And these are, I've just grouped the causes on the slide, and I'm going to work through these individually. We've talked about embryos, and that embryo aneuploidy is the most likely reason. And these errors happen during meiosis most commonly, and that means the division of the sex chromosomes, but also can happen during mitosis. So the embryo, the sperm and egg have come together to create the embryo, and then in the division of the embryo, errors occur. The age increases your chance of embryo aneuploidy significantly, and so we see that in our IVF success. And if you see along the third line there of the non-PGTA, which means non-tested embryos, you can see as women got older, the decline in the pregnancy rates, and that comes from the US data. There's also a thought that there may be a cohort effect, which means that they've noticed that sometimes people just have a bad cycle, and that you may have poor implantation, you might have had poor fertilization, and this isn't repeated if a second cycle happens. So that is possible in the younger age groups. We know that aneuploidy is the main cause, but we still know that at least half of our embryos don't result in a pregnancy. And so this does make us think about what else might be happening. Scientists have looked at mitochondrial DNA content. So remembering that the mitochondria are your batteries within a cell and provide the energy to a cell. It was found that euploid blastocysts that failed to implant had a higher load of mitochondrial DNA. So this has been led to this hypothesis of an embryo being, a quiet embryo being better, and that embryos that have normal developing embryos have a lower metabolism and are tolerated better. And they have looked at measuring mitochondrial DNA load, but this is an area of research only and is not currently a test. So moving away from embryos to thinking about other causes, we know that lifestyle is incredibly important for both for both men and women, because it's about getting good quality embryos. I'm not going to talk too much about diet and exercise and smoking, alcohol and drugs, because most of my patients who have had failed transfers are just doing everything they can and are well aware of these. But just to say that diet is extremely important for both men and women. Exercise is good, but not too much and not too little. And avoiding these other factors like smoking, alcohol and drugs is important. Sleep is very important. All of our sex steroid hormones are released with our circadian rhythm, and it is recommended that we have 8 hours of sleep a night. Stress is very difficult because not conceiving is very stressful, but stress does result in the release of cortisol, and we know that this does create, chronic stress does create a inflammatory, sort of chronic inflammatory process. You need a lot of resilience when you are going through IVF and are having failed transfers, and using a psychologist or interventions to manage the anxiety of treatment is likely to help. Vitamin D we do recommend on the basis of that it may help create good embryos, although there's insufficient data on whether there's benefit for this, but it seems to make biological sense. BMI, extremes of weight do result in less live births and also increase the risk of miscarriage. And so this US data again, a study just recently reviewed 56,000 euploid transfers, so embryos that were normal, and saw that the live birth rate declined with higher BMI. There was also a reduced birth rate with BMI less than 18. So the higher BMI and lower BMI group does affect your chance of having an ongoing pregnancy. And they define this with that there was a 2% reduction. So with each unit increase in your BMI, it results in a 2% reduction in the chance of pregnancy. Reassuringly though, overall, the live birth rates were still good, even for women with BMI between 30 to 40. So although there was a reduction, the overall live birth rates were still good. In terms of thinking what is ideal, there is this Goldilocks, or this sweet spot of a BMI, which is between 23 to 25. But be reassured that your chance of pregnancy is overall still good. Parental chromosomes are important. They can be the cause if a parent has an alteration in their chromosome. This means that they may make more unbalanced embryos or more abnormal embryos. This is increased in patients with recurrent implantation failure, but the chance is still very low, so only affecting 2.1%. There will be research in the future that is possible that a mutation may be found, which may explain why some women have recurrent implantation failure. Potentially a mutation showing that the ability of the embryo to implant or be euploid is possible. Looking at anatomical reasons, this is certainly something we look for. And so thinking about inside the uterus, anything that distorts the cavity of the uterus where the embryo is trying to implant. We look for polyps, fibroids, which are called submucosal, meaning they're coming into the cavity, or adhesions that are in the cavity are potentially important. The other things we think about is cesarean scar defects. They're very commonly seen, but certainly ones where there's abnormal bleeding, or we see fluid inside the cavity where an embryo is trying to implant, are important. Adenomyosis is when you have endometrial-like tissue in the muscle. And so I've just realised I've got a pointer, so I'll try this. Oh, no. Okay, I'm not going to try that. Sorry, anyway, you can see there adenomyosis, and so the little red dots in that muscle are showing those areas of endometrial-like tissue. Endometriosis we can usually find with an ultrasound, although superficial disease we may not. And then hydrosalpinges is describing swollen, damaged fallopian tubes, and these can harbour old bacteria, and you can, if there is old bacteria and fluid in these hydrosalpinges, these potentially will drop into the uterine cavity, which can interfere with implantation. So hysteroscopy, in investigating recurrent implantation failure, usually one hysteroscopy will be done, and that's to check that cavity. Conflicting data, but there is a study showing it's a small increase in the live birth rate. Certainly, if we find something, then we will remove it and try and correct that cavity. So moving on to the endometrium. So the endometrium is vital for an embryo to implant. And the first thing we look at is what the thickness of the endometrium is during the cycle. We use, during a thawed embryo transfer, we will do a measurement of the endometrium by ultrasound. Currently, we use a 7mm cutoff, as a study by Liao showed that this was best. However, pregnancies do still happen at measurements lower than this. Certainly, if we see a thin endometrium persistently on scan, it does raise the possibility that there may be intrauterine adhesions, and that's important to exclude. So chronic endometritis, this describes the inflammatory process which is impacting the endometrium. Chronic endometritis is subclinical, so this means you won't have any symptoms like bleeding, but there is this polymicrobial infection. This is diagnosed on endometrial biopsy, where we look for plasma cells, and the treatment is antibiotics, usually with 2 weeks of antibiotics. The prevalence of this amongst women with recurrent implantation failure is at least 30%. Currently, there is insufficient evidence that that treatment helps, but certainly we will treat this. In recent years, the Human Microbiome Project has highlighted the importance of microorganisms in health. 10% of this resides in the genital tract, and the endometrium is not sterile. It used to be thought that it was sterile, but it's not. This led researchers to examine the microbiome, and in women with recurrent implantation failure, it was found that there were lower lactobacilli in the vagina, and this led to the theory that this imbalance of the microbiome may be a factor. There have been treatments tried, including implants of lactobacilli, and these haven't shown benefits. So we do know there's an association, but we currently don't understand this fully. We know the endometrium has to be ready for the embryo to implant, and we know that there is a window of receptivity for implantation. And this led researchers to look for a molecular diagnostic, to develop a molecular diagnostic tool. They used next generation sequencing to analyse the expression of 236 genes within the endometrium, and developed a test called the ERA test, which was gave people a personalised embryo transfer. This was used quite widely and was hoped to be the answer to why euploid embryos weren't resulting in pregnancy. However, there has been good data that this test does not improve the implantation rate in IVF and in implantation failure. So this test is no longer being offered. And this slide is just a summary slide of the studies on endometrial receptivity tests in women with recurrent implantation failure, but basically no evidence of benefit. And just to, interestingly, that bottom study by Consolino was actually one of the developers of the test, who importantly did a study and reported that there was no benefit. People are looking at endometrial function, and these are the mRNA tests, another test that have been developed. Currently no evidence for these, and so not widely recommended. The immune system, this takes me to the immune system. The immune system is intricately involved in the initiation and maintenance of pregnancy. And for success, the immune system must develop selective tolerance to the fetus while keeping competence against pathogens that might happen. So it's a fine balance, and there is a dialogue between embryos and the maternal decidual endometrium to determine the immune response. So this is a slide which I'm not expecting you to look and understand, but basically the slide, can you see my mouse? Shows the embryo invading and then the immune response within the endometrium to allow the invasion, and then the remodeling that happens. So this has led to people thinking that was it a excessive response of the mother's immune system that stops implantation. It is important to remember that the fetus is separated from the maternal immune system by the placenta, and currently the test that we do to see if there may be an immune factor is ANA, which is a general screen for autoimmune disease, and thyroid antibodies. There are other tests that are out there being performed by some clinics, but these are not recommended as they haven't been found to be helpful. In particular, NK cell testing or natural killer cell testing, which I'm going to talk about a little bit more, in the blood and in the uterus, and then uterine T lymphocytes, blood cytokines. People have looked at the KIR receptors, which are the receptors, the main class of receptors on the maternal natural killer cells. And then they have also looked at fetal HL So HLA are your proteins or markers on most cells of your body, which help your immune system identify what belongs to you and what's different, and that's mainly used in transplant. And there was some suggestion about an incompatibility between the HLA type of the fetus and the mother's Q receptor being an issue. And there is some evidence for this in later problems such as high blood pressure and pregnancy, but there hasn't been any evidence for this in early implantation. So I did want to talk about natural killer cells because they were the hot topic for quite a long time. They sound bad, and there was this concept that the woman was rejecting the embryo and that the natural killer cells were responsible. So natural killer cells are found in your peripheral blood. They're also in the endometrium and lymphoid tissues. The natural killer cells are the main type of white blood cells in the endometrium, and they are increased significantly in just prior to implantation in an early pregnancy, and so this is why they've been studied so much. They secrete cytokines, so they moderate that immune response, but they do not kill cells, which is what your peripheral blood natural killer cells have two jobs, which are to kill or lyse cells as well as to secrete cytokines. There has been a study looking at measuring uterine natural killer cells, and it was found to have no difference on live birth rate. So in summary, we know natural killer cells are very important, but we don't fully understand their function in pregnancy and normal pregnancy at present. How am I going for time? Oh, I'm being slow. So thrombophilias, this is a clotting abnormality where you have a tendency to clot, and thrombophilias can be inherited and they can be acquired. So the successful implantation of an embryo requires the invasion of the endometrium. The embryo embeds completely in the endometrium, and by the end of the week 2, it's developed an intricate lacunar network, which means it has a vascular connection between mother and baby, and that allows the exchange of nutrients and gas exchange. So this is, I don't know if you can see, but all these sort of large red areas are these sort of lovely, this is the lacunar network. So this is, these thrombophilias where you have an increased clotting abnormality, people have thought that if you had an inherited abnormality, would that increase your risk of recurrent pregnancy loss and potentially implantation failure. There has been a large study looking at this, and they found no benefit to screening or for treatment on miscarriage. There's acquired thrombophilias are our antiphospholipid syndrome, and we do tests for this, even though there's no evidence that it's increased in implantation failure, but it does have significant fetal and maternal effects in pregnancy, so we test for it as treatment would be needed. Progesterone. Progesterone is the hormone that supports early pregnancy and pregnancy. So initially produced by the corpus luteum until the placenta's there, and so in a transfer cycle we provide the support. And this is given in Europe and New Zealand and Australia vaginally and sometimes orally. And in the US, they use progesterone injections. We know that the levels are important, and if in a natural cycle we see an early rise in your progesterone, that this means that the endometrium is no longer going to be receptive because there's an asynchrony with the embryo. We also know that potentially low levels of progesterone on your day of transfer or the day prior may lead to poorer outcomes. So often we'll supplement with extra progesterone on top of the sort of standard. And this is thought to be that maybe some women have a variable vaginal absorption. Sperm DNA integrity, so creating good embryos, so having good DNA from the egg and from the sperm is important. And this has led to tests looking at DNA fragmentation, which we know is increased in older men, and smoking, obesity, and pollution. Also varicocele, which is when there's varicose veins or dilated veins around the testes, can be an important cause of increased DNA fragmentation. So there is a test for this, which was thought to be important. We still think it's probably important, but there's no current evidence that high levels of DNA damage affects live birth rate. The environment, there are so many endocrine disrupting chemicals. It's scary. These are chemicals that basically interfere with the way the body's hormones work, and some of them mimic hormones and trick the body that they are hormones, and others may block the way that hormones function. So that these endocrine disrupting chemicals are everywhere. But we do recommend that people try and reduce their exposure as much as possible. So a summary of investigations so ESHRE produces a summary of investigations that they recommend. So I've just included that for you. So not having multiple failures does make us look for tests. It also makes us look for interventions. We're always looking for studies to try and help improve the chance of implantation. And these are the tests that I'm going to run through. I am aware that I'm running a bit over time, but I'll try and run through this a bit quicker. Basically, these interventions, the main ones being pre-genetic testing for aneuploidy, endometrial scratch, flushing of uterus with different things, immune modulators, heparin, and long down regulation. So embryo selection is by pre-genetic testing for aneuploidy. So this is when a day 5 embryo, which has the inner cell mass, which will become the baby, and then the outer cells will become the placenta. We can take 5 or 6 of those outer cells and send it for genetic testing. We assume the result of this reflects what's happening in the inner cell mass, which will become the baby. And the result will come back as saying euploid, aneuploid, or sometimes mosaic, which means that some of the cells are abnormal and some are normal. The result of this usually takes 6 weeks, and in terms of the evidence for it, it hasn't been shown to increase the live birth rate, but if you are older, there is benefit in that you're potentially avoiding transfers that were futile, potentially get to your embryos that have more chance quicker, and reduce the risk of miscarriage. There is a cost to it for each embryo that's checked, and there is a risk of an embryo being lost in the thaw process. If we do this, we prefer to do it with fresh embryos than ones that are frozen and then re-thawed. Endometrial scratch. This is when a scratch or a biopsy is taken from inside the uterus or endometrium, the cycle before the transfer. The thought around this was that there would be a wound healing response, which might respond in a better chance of implantation. There's been large reviews on this that haven't shown any benefit in IVF patients, but also patients who'd had 2 failed transfers previously. Flushing of the uterus. We use HCG sometimes. This is the same as the trigger that's given at egg collection. And the thinking around this was that it may help with the embryo implantation and improve the mother's immune tolerance. There's been a study showing an improvement in the live birth rate in patients who had 2 failed transfers. There's also been other studies showing no benefit. So at present, it's inconclusive whether it's helpful. We've also flushed the uterus with platelet-rich plasma, or PRP. This means that we'll withdraw blood from the mother. It's spun in a centrifuge to separate the plasma. The plasma contains growth factors and cytokines, and PRP is used a lot in other fields, and so there haven't been many safety concerns with this. So this is typically used for women with thin endometrium, and there was a study showing some benefit for women with thin endometrium during their scan. But again, really small studies, so hard to say for sure if there's any benefit. Immunomodulators, so this is on the idea that it was the mother's immune system being overactive that was the problem, and there have been lots of things tried to try and dampen the immune response. So intravenous immunoglobulin, intrauterine peripheral blood mononuclear cell treatment, that's basically your own white blood cells being flushed into the uterus. Granulocyte colony stimulating factor, I will talk about. People have tried steroids, intralipid, leukocyte immunization therapy, or LIT, is on this theory that the the immune system is rejecting the father's is reacting to the father's DNA, and basically it's withdrawing blood from the man and then spinning it to separate off the white blood cells, and then they were injecting minute levels of the white blood cells under the skin of woman so that she would develop a better immune tolerance. No evidence for this, but that's what is being offered. Then there are drugs, tacrolimus, anti-TNF agents, hydroxychloroquine. All of these act to as immune suppression drugs and are used in other things like Crohn's disease and arthritis. But basically none of these treatments have been shown to have any benefit and are not recommended. But I am going to talk about a few of them a bit more. I thought I was. Sorry, I must have cut a slide, so it might come up. I'll just move to heparin. So heparin has been used on the basis of this may help with the implantation and the and it has been definitely has a benefit for antiphospholipid syndrome and preventing placental thrombosis and infarction. But in terms of evidence for it helping with recurrent implantation failure, there is no evidence that improves the live birth rate. It does have a good safety profile. There is a small risk of bruising and bleeding. It's not currently recommended. I just mentioned aspirin, no benefit in improving IVF live birth rate, possibly as a benefit in recurrent pregnancy loss. And then the Colorado protocol I just wanted to mention because it is used quite a lot. This, people have developed these sort of combinations of things to sort of try and help with all possible aspects. And this describes using low-dose aspirin from the start of the cycle and then 5 days of prednisone with augmentin just before transfer. But there isn't any evidence for this improving chances. The Bondo protocol is another protocol that we use. This was developed by Gavin Sachs in Australia and used for women with repeated IVF failure. And it basically means that you use prednisone from the start of the transfer and clexane or heparin, and you continue that until 12 to 16 weeks. He did report a study in 2022 of his transfer cycles, and he didn't show any improvement in live birth rates. He did say in his subgroup analysis that women that had high natural killer cell activity on their blood showed a benefit. However, there are issues with blood natural killer cell measurement. Long down regulation, we use this for women with adenomyosis, but there are also potentially a large group of women who have undiagnosed endometriosis or adenomyosis, and this may improve chances. Basically, it means making somebody menopausal for 2 months because we switch off their ovaries with an injection of Zoladex, and we may give letrozole, which is a tablet as well, for 2 months. There have been 2 retrospective reviews which showed an improved live birth rate with 2 months of long down regulation in women that had 3 failed transfers. We're aware that not having failed transfers is incredibly stressful, and people can lose faith in treatment, and we'll look at alternatives. And most women, to be honest, have already been using alternative medicine when they come to a fertility clinic. But I did just want to mention acupuncture because I do get asked this a lot. And there was a study in 2021 which looked at whether acupuncture at your transfer improved the chances of live birth, and it didn't show a benefit. So this is just a summary slide of AIRSHRA good practice recommendations on recurrent implantation failure. So in conclusion, true recurrent implantation failure is rare. We've probably been overdiagnosing this as we didn't have a definition before. The evidence for our add-on interventions is unfortunately poor. It is helpful that we now have a definition for recurrent implantation failure, as this will identify women who do need further investigation, and it will also help with research into this area. For women and couples who are having failed transfers, it's important to exclude or correct known causes. We do need to take an individualised approach and work with you to work out the best steps to get you there for pregnancy. Thank you. So the question is, can an endometrioma in the ovary affect recurrent implantation failure? So the endometrioma in the ovary indicates that there's quite significant endometriosis. And that means that there's inflammation in the pelvis. It may have some benefit, and so that would be an indication where we may consider down regulation prior to an embryo transfer. But the endometrioma itself, just on its own, potentially not, but it is a sign that there's significant endometriosis, so it might be worth considering down regulation. Yeah, so I've got not a question, just a comment. How disappointing so many of the tests of those of us suffering from recurrent implantation failure have no solid evidence to support them being a benefit. I know. It's really disappointing. Tests get developed and then we get hopeful, like this personalised, the ERA test. I do think we have suffered by not having a definition, and that I'm hopeful now that there is a definition, that there will be better tests developed and better treatments.
So interesting. Thank you so much for sharing all of that with us. We don't have heaps of questions rolling in, and that's often reflective of the content and how much information has been delivered through the webinar. So, but I just wanted to just do one last call for questions if anybody has anything else that's burning on their mind. Well, here we go.
Yeah, so this is a very important question. After how many failed transfers do you do before you give up and say that's enough? And that's a really difficult question to answer. And basically at some point we would be thinking, do you keep, for instance, if you've had 5 euploid embryos back, and you've got 4 frozen, do you keep going with those, or would you be thinking, is surrogacy a better option for me? So that's a really difficult question to answer, and at present we can't say. I think that would be something that would have to be discussed with your doctor, and whether you would be open to using a surrogate if that was thought to be the best next step. So the definition is basically 3 euploids. So those are embryos that have been tested and have normal chromosomes. And if they're not embryos that have been tested, the number of transfers depends on how old you are. So if you are 35, you would need to have 4 transfers, and then I think I said if you were 41, it was to 42, it was like 13 transfers.
Oh, that person's just sort of also asked if the slides will be available. And just so everybody knows, this presentation will be available on the Fertility New Zealand website and our YouTube channel after tomorrow. So it will be there for you to come back and review, be able to pause and have a good look at the slides and so on in the future.
So the Emma-Ellis test, it's a test. It may be, we just don't have the evidence of whether it's beneficial, and there is a cost to doing the test. In terms of looking for endometriosis, ultrasound, so having a sonographer who is good at looking for endometriosis, we can usually diagnose this with ultrasound. Of course, we will miss a very sort of early superficial endometriosis, but I think ultrasound is very good at diagnosing and a lot cheaper. So it is something that's available, but there's no evidence for it. But it comes down to personal decision regarding the cost. Oh, sorry, on this one.
Sorry.
So are progesterone shots better than vaginal ones? The evidence for this is the success rates are good with vaginal progesterone. Progesterone injections aren't available in New Zealand. There is debate about whether injections, there may be some benefit for progesterone injections, but Europe, there's also a downside of injections, and vaginal progesterone is a lot easier to use. So, sorry, I haven't answered this very well. But basically, vaginal progesterone is very good, and we can supplement with oral progesterone. I do have some patients who might source progesterone injections, but there's no clear evidence that injections are better than vaginal. Yes, currently PGTA is the only way to test for euploid embryos. No, so the question was, oh, sorry, I'm getting lost. I had 2 failed transfers and antibiotics for chronic endometritis, and then a successful pregnancy. There's a lot of research on chronic endometritis. There's just not good evidence. Partly this may be the problem that a lot of people that were diagnosed with implantation failure, in fact, didn't have true implantation failure because we didn't have a definition. All of us would still treat chronic endometritis and still consider this important. And then there was a question, would there be any difference in success rates of natural or medicated cycles for implantation? No, this has been studied that there's no difference in pregnancy rate. What have we got? Does having PCOS affect your chance of a successful IVF cycle? The PCOS, usually women with PCOS have high AMHs, which means they get a high number of eggs, and that will often translate to a good number of embryos. So, no. So down regulation, how does it improve embryo implantation? So adenomyosis, which is when you have the endometrial-like tissue in the muscle. It is thought that this may affect the contractility of the uterus. It has some hormones. It may also change the immune regulation within the uterus, and so inactivating those implants and endometriosis inflammation is thought to be helpful.
Final question, Anna.
What are your thoughts on fresh versus frozen transfers? This is debated a lot as well on conferences, whether we should be just moving to frozen transfers. And there may be a small benefit in frozen transfers over fresh. It does depend, obviously, whether you have the option of frozen transfers. If there is 1 day 3 embryo, then we usually would recommend that is transferred in a fresh cycle, rather than risking the chance of it not surviving a thaw. I hope that's
cool. Thank you so much, Anna. There was a wee flurry of questions there at the end, which sometimes it can take a wee bit to get our head around what questions to ask. So thank you everyone who submitted a question. I'm sorry if we didn't quite get to everybody's this evening. But thank you so much, Anna. Such valuable information and insight on this topic. Really appreciate your time this evening and the work and thought and experience that has gone into this webinar this evening. Make sure to follow us and keep up to date on our webinar series. We've got lots on our library online, and our next one is Let's Talk About Sex on May 21st with medical herbalist and Fertility New Zealand board advisor Jo Barnett. Jo's going to talk about tracking your cycle, signs of ovulation, timing of sex, and much more. This webinar is particularly aimed for people who are new to the journey and still figuring out some of these things. However, there's sure to be excellent information for anybody that wants to attend. Please also, as mentioned, have a look at our library online. Loads of past webinars over the last few years that will cover that cover such a huge range of topics relating to this. Big thank you again to Anna tonight for your time, and also a thank you goes to Merck, who is our webinar sponsor and help fund this series for us every year. And a big good night and a big thank you to everybody for attending tonight, and those that are still online after this time. I hope that you all have an enjoyable rest of your evening, and hopefully we will see you again. Good night.